It's time to cut through the noise. Welcome to DrMcPharma, your daily dose of clear, evidence-based insights into health, healthcare, and pharmacology. We're here to break down the science, demystify the prescriptions, and empower you to have smarter conversations with your doctor. This is DrMcPharma. Knowledge is the best medicine.
The U.S. healthcare system, it's confusing, it's definitely expensive, and for most of us, it's just this unavoidable, sometimes really overwhelming thing in our lives.
Yeah.
You know, whether you're trying to figure out an insurance card or decode a medical bill or just find out where to get care, it can feel incredibly complex, almost paradoxical, really. So our mission today on the deep dive is to try and cut through some of that complexity. We want to extract the most important insights from the sources you've shared with us about this system's unique structure, how it's financed, and maybe most importantly, how it actually performs.
And that paradox you mentioned, that's really, well, it's at the heart of it all, isn't it?
Yeah.
The United States spends way more on healthcare than any other developed nation, yet we don't provide universal coverage. And we still struggle quite significantly with access, affordability, and overall public health outcomes. Our goal in this deep dive is hopefully to give you a clearer understanding of what makes this unique hybrid model tick.
Okay, let's start with the numbers because they're, well, super startling and they set the stage for everything else. In 2022, national health spending in the U.S. hit an astounding $4.5 trillion.
Trillion, yeah.
Just think about that. It's roughly 17% of our entire gross domestic product. So nearly 1 out of every $5 spent in the whole U.S. economy is going towards healthcare.
It's huge.
And if you compare us globally, the U.S. spends almost twice as much per person on healthcare as the average high-income country. So given these incredible figures, how do we make sense of our outcomes lagging so far behind? What's the disconnect there?
It's such a critical question, and it's really where that paradox becomes crystal clear. Despite this massive financial investment, U.S. health outcomes often lag, sometimes significantly, behind our peer nations. So, for instance, life expectancy here was 77.5 years in 2022. Compare that to an average of 82.2 years in similar OECD countries. That's a big gap.
Whoa.
And we also see higher rates of infant mortality, 5.4 per 1,000 live births here versus an average of 3.5 elsewhere. Maternal mortality is another really stark example. 22.3 deaths per 100,000 live births in the U.S., compared to just 8.7 on average in comparable countries.
That's terrible.
It is. And avoidable deaths, deaths that could have been prevented or treated with timely care, they stand at 177 per 100,000 here versus 94 on average elsewhere. But the core insight from all the sources, really, isn't that Americans use healthcare more. That's not it.
Right.
It's that we simply pay more for almost everything, a doctor's visit, a prescription drug, a hospital stay. This singular fact, driven primarily by higher prices for medical services and products, that fundamentally explains the American healthcare paradox more than anything else.
So if it's not that we're using more services, what is the structure, the architecture that creates this incredibly costly sort of outlier system? Because unlike most other developed nations, the U.S. doesn't provide universal health care coverage, right?
That's exactly right.
Instead, we have this fragmented patchwork of financing and delivery. And it seems like it's predominantly handled by private companies, private hospitals, clinics, doctor practices.
Correct. The financing is this really complex mix. You've got employer-sponsored private insurance, which is actually the biggest chunk. Then you have major government programs like Medicare for seniors and Medicaid for low-income individuals, and then, of course, people paying directly out of pocket.
Okay.
And this setup creates this fundamental tension. Just imagine a private insurer, right? Their goal is often, maximizing profit. So maybe they try to limit costly treatments or maybe avoid enrolling people they think will be expensive, high-risk patients.
Right, the business incentive.
Exactly. Now, contrast that with a public program like Medicaid, which is specifically designed to be a safety net for people who can't afford care, pretty much regardless of the cost. This inherent clash of philosophies, profit versus social good, it's woven right into the fabric of American healthcare. And it directly impacts the kind of care you might receive.
Okay, so to really understand the financial challenges that, you as a patient might face, you really need to know the language of healthcare finance. We're talking about these things called cost-sharing mechanisms. You've probably encountered them. They're supposed to make you sensitive to price, but as we'll discuss, they often end up being major barriers to getting care. So first, There are premiums. That's the fixed amount you pay, usually every month, almost like a subscription fee for your coverage. You pay this whether you go to the doctor or not.
Right, just to have the insurance.
Exactly. Then there are deductibles. Now, this is a specific amount of money you have to pay out of your own pocket for covered services before your insurance plan starts paying anything at all. So, for example, if your plan has a $2,000 deductible, you're on the hook for the first $2,000 of your medical bills for that year.
Which can be a lot for many people.
Oh, absolutely. And here's the catch. Plans with lower monthly premiums often come with much higher deductibles. This creates what people call the underinsured problem. You have insurance, but the deductible is so high, you effectively can't afford to use it.
Yeah, that's a huge issue.
So after you've met that deductible, you'll often run into copayments or just copays. These are usually fixed, flat fees you pay for a specific service right when you get it, like, say, a $30 copay for a primary care visit.
Okay, straightforward enough.
And then there's coinsurance. This is your share of the costs, but it's calculated as a percentage of the bill after you've met your deductible. So if you have 20% coinsurance, you pay 20% of the approved cost, and your insurer pays the other 80%.
So that can vary a lot depending on how expensive the service was.
Exactly. It's not a flat fee like a copay. And finally, there's the out-of-pocket maximum. This is really important. It's the absolute most an individual or family will have to pay for covered healthcare services in a single plan year. It's a crucial financial safety net.
The cap, essentially.
Right, a cap on your liability. It includes all the money you spent towards your deductible, your copays, and your coinsurance. But, and this is important, it does not usually include what you paid in monthly premiums. Those are separate.
You know, listening to all these terms, premiums, deductibles, copays, coinsurance, out-of-pocket maximums, it raises a question. Do these mechanisms actually work as intended? I mean, are they effective? Because it really sounds like they could also create some pretty significant barriers to actually getting care.
Right. That's exactly the issue. While the idea is often to discourage people from using, unnecessary care,
It might make them pretty sensitive.
what we often see is that these mechanisms, well, they don't really distinguish between care that's essential and care that isn't.
Oh, okay.
So here's the reality. While they're designed to make you think about the price, often they just make you hesitant to seek care when you're actually sick.
Yeah, you might delay going to the doctor.
Yeah, exactly. The real insight here is that these financial tools don't differentiate well between necessary medical treatment and maybe something more elective. So patients, even those with insurance, get forced into this really tough choice. Do I take care of my health now or protect my financial stability?
And that's not really a choice anyone should have to make.
No. And it's not just a challenge. It feels like a systemic design flaw. It creates this large group of underinsured people, which, as you said, can lead to people delaying care, getting sicker, and ultimately costing the system even more in the long run.
Yeah, worse health outcomes and higher long-term costs.
Right.
Makes sense.
So with all these financial hurdles, let's look at the actual players involved in this whole system. We can kind of simplify it by thinking about three main groups. Patients, obviously, the ones receiving care. Providers, the ones delivering the care, doctors, nurses, hospitals. And payers, the entities like insurance companies or the government that actually finance those services.
Right. And that relationship between the payers and the providers, it's really this nexus of conflict sometimes, but also collaboration. So payers set up these provider networks. They contract with specific doctors and hospitals, the in-network providers, who agree to accept negotiated, usually discounted payment rates.
And if you go outside that network,
If you go out of network, yeah, you can face drastically higher costs, or the service might not be covered at all.
got it.
The payment models they use also hugely influence how care is delivered. Hospitals, for example, are often paid through diagnostic-related groups, or DRGs. That's basically a single predetermined payment for treating a specific diagnosis, like pneumonia or a hip replacement.
So that encourages efficiency, presumably. Get the patient treated effectively within that fixed amount.
Exactly. It incentivizes efficiency. But physicians, historically at least, have often been paid on a fee-for-service basis. That means each individual service, each test, each procedure, each visit is billed separately.
Which sounds like it could incentivize doing more services, whether they're strictly necessary or not.
Precisely. And that's widely seen as a major driver of rising healthcare costs in the U.S., the incentive to increase the volume of services. So to try and control that, payers often implement prior authorization. This means the doctor needs to get approval from the insurance company before providing certain services or prescribing certain medication.
The dreaded prior auth.
Yes. While the idea is to prevent unnecessary or overly expensive treatments, it's become a huge source of administrative burden for doctors' offices, and, more importantly, it can lead to significant delays in patient care, patients waiting for approval for needed treatment.
Yeah, you hear stories about that all the time, and this really gets to the heart of it, doesn't it? That traditional fee-for-service system, it just creates this, well, this dysfunctional dynamic. You've got providers incentivized to do more, payers incentivized to restrict access to control costs, and then patients, especially if they have high deductibles, incentivized to avoid care because they're worried about the bill. It seems like everyone's pulling in different directions.
That sums it up perfectly. And that's precisely why there's been this slow but steady push towards value-based care models. These models represent a real systemic attempt to try and realign those incentives. The goal is to pay providers based on the quality of care and patient outcomes, rather than just the sheer quantity of services performed.
Moving away from more is better.
Towards better is better, exactly. Fostering more collaboration, focused on the patient's actual health needs. It's a fundamental shift in thinking.
Okay, so with all these moving parts and different incentives, how do Americans actually get health insurance in the first place? It sounds like a really fragmented landscape, not like a single system you see in other countries.
It is very fragmented. There are multiple distinct pathways to getting coverage. The biggest one, the primary source for most working-age Americans and their families, is employer-sponsored insurance, or ESI.
Right, through your job.
Exactly. This is really the bedrock of the U.S. system, covering something like 165 million non-elderly individuals, which is about 60% of that group. Interestingly, its origins actually go back to World War II, when wage controls were in place, and employers started offering health benefits as a way to attract workers.
Oh, I didn't know that.
Yeah, but over time, the cost of ESI has become a massive financial burden for both employers and employees. In 2023, the average annual premium for a family plan was nearly $24,000.
Wow.
And workers, on average, had to contribute over $6,500 of that themselves, often through payroll deductions.
And I bet it varies a lot depending on the company size.
Huge variation. Only about 39–40% of the very smallest firms even offer health benefits. And even when they do, the workers at those small firms often face much worse financial terms, like significantly higher deductibles. We're talking maybe over $5,000 on average at small firms compared to closer to $3,500 at large firms.
So your coverage really depends on where you work.
Absolutely. Yeah. Now, for people who don't get insurance through work, or maybe they're self-employed, the individual market and the ACA marketplaces are key. The Affordable Care Act, the ACA, really overhauled this market by creating these online health insurance marketplaces, like healthcare.gov at the federal level, where individuals can compare and buy private insurance plans.
And lots of people use those now, right?
Yeah, enrollment exceeded 24 million people in 2025. And a crucial part of this is the availability of federal subsidies, known as premium tax credits, which help make the monthly premiums more affordable for people based on their income.
And those are the plans with the metal tiers, silver, gold.
Exactly. Bronze, silver, gold, platinum. Those tiers basically tell you how you and your insurer will split the costs. Bronze plans have lower premiums, but higher out-of-pocket costs when you get care. Platinum plans are the opposite, high premiums, but lower cost when you need services. Silver and gold are in between. It's about cost sharing, not necessarily the quality of the doctors in the network.
Okay, that makes sense. So we have employer plans, individual market plans. What about government programs?
Right. Then you have the major public programs. First, there's Medicare. Established way back in 1965, it's the federal health insurance program, mainly for people aged 65 or older, but also for younger people with certain disabilities. It covers over 50 million Americans.
And Medicare has different parts, doesn't it? It seems complicated.
It can be. To simplify, think of Part A as hospital insurance. Most people don't pay a premium for this if they or their spouse paid Medicare taxes while working. Part B is medical insurance, covering doctor visits and outpatient care. You pay a monthly premium for this. Then there's Part C, known as Medicare Advantage, which are private plans offered by insurance companies that bundle Parts A, B, and often D together, sometimes with extra benefits. And Part D is the prescription drug coverage, which is also offered through private plans.
Okay, a lot of parts. And the other big one is Medicaid.
Yes, Medicaid and CHIP, the Children's Health Insurance Program. This is a joint federal and state program designed for low-income populations. Individuals, families, children, pregnant women, people with disabilities. It covers over 70 million Americans. CHIP specifically helps children and families who earn too much to qualify for Medicaid but still can't afford private insurance.
And since it's joint federal and state,
Exactly, because states co-fund and administer the program under federal guidelines. There's significant variation from state to state in terms of who is eligible, what benefits are covered, and how the program operates. It's not uniform across the country.
So when you step back and look at all these different pathways, employer, individual market, Medicare, Medicaid, what does this fragmented structure really mean for you, the individual trying to navigate it?
Well, it fundamentally means that your access to healthcare, the quality of the care you might receive, and certainly your financial risk, are heavily influenced, maybe even predetermined, by things like whether you have a job, how much you earn, how old you are, and literally which state you happen to live in.
It sounds like it creates almost different tiers of healthcare within the same country.
That's a very accurate way to put it. It effectively creates a tiered system where your pathway largely dictates your healthcare experience and financial exposure.
Let's circle back to that enormous spending number, $4.5 trillion in 2022. It's just such a staggering amount. Where does all that money actually come from, and where does it end up going?
The financing is incredibly diverse, as you might expect in this system. Looking at 2019 data, the largest single sources of funds were actually the federal government, paying about 29%, and households themselves, paying about 28% through premiums, out-of-pocket costs, etc. State and local governments and private businesses cover the rest.
So nearly a third from the feds and a third from us directly.
Roughly, yes. And when you look at where that money goes, the biggest slice of the pie in 2022 was hospital care, accounting for over 30% of all spending. The second largest category was physician and clinical services, at nearly 20%. So just those two areas, hospitals and doctors, make up over half of all U.S. health spending.
And here's that crucial point again, right? The key finding in so many analyses isn't that Americans are just getting way more healthcare than people elsewhere.
No, that's generally not the case.
Instead, the main reason our costs are so high is that the U.S. pays significantly higher prices for almost everything. Every service, every drug, every procedure.
That's the consensus, yes. Whether it's an MRI scan, a common prescription, or a day in the hospital, the price tag tends to be much higher here.
And things like hospital consolidation, where big hospital systems buy up smaller ones, reducing competition, that plays a big role too, doesn't it?
Absolutely. Less competition often leads to higher prices. But there's another huge factor driving costs: administrative complexity. This multi-payer system, with thousands of different private insurance plans, each with its own rules, forms, and billing procedures, it generates an enormous amount of administrative waste.
Like paperwork and bureaucracy.
Exactly. The U.S. spends over $1,000 per person every year just on administrative costs related to healthcare. That's nearly 5 times the average of other wealthy countries. Think about that money spent on administration, not on actual patient care.
Wow, 5 times. That's incredible.
And beyond just inefficiency, there's also the issue of fraud, waste, and abuse. A substantial portion of healthcare spending is unfortunately lost to things like improper billing, unnecessary services, or outright fraud. Estimates vary, but some suggest hundreds of billions of dollars are diverted away from actual patient care each year due to these problems. For example, one government report estimated improper payments in Medicare alone total over $80 billion in 2018.
Hundreds of billions. That's just mind-boggling. So how is this incredibly complex, sprawling, fragmented system even governed? Who's in charge? It's clearly not one single entity.
Definitely not. It's governed by this decentralized and quite complex web involving federal, state, and local government bodies. Plus, you have congressional committees, the courts, lots of players.
So at the federal level, who are the main players?
The big one is the Department of Health and Human Services, or HHS. It's the main federal agency overseeing health. And its largest division, by far, is the Centers for Medicare and Medicaid Services, CMS. CMS is an absolute behemoth. It administers Medicare, Medicaid, CHIP, and it also oversees the ACA health insurance marketplaces.
So it touches a huge number of people.
Immense. Its budget accounted for nearly a quarter of all federal spending in 2023, and it serves over 170 million Americans through its various programs.
Wow. Any other key federal agencies we should know?
Yes, definitely. There's the Food and Drug Administration, the FDA, which is responsible for ensuring the safety and effectiveness of drugs, medical devices, and food. You have the Centers for Disease Control and Prevention, the CDC, which focuses on public health, disease tracking, and prevention, and the National Institutes of Health, NIH, which is the largest source of funding for medical research, not just in the U.S., but in the world.
Okay, so that's the federal level. What about states and local governments? You mentioned they play a big role too.
A crucial and very powerful role. States are primarily responsible for licensing healthcare professionals, doctors, nurses, and facilities like hospitals and clinics. They also regulate the health insurance plans sold within their state borders. And, as we discussed, they co-fund and administer their own Medicaid programs, deciding on eligibility and some benefits within federal rules.
So that state-level control explains a lot of the variation we see across the country.
Exactly. That state autonomy is a primary reason why healthcare access, insurance coverage rules, and even the scope of Medicaid benefits can vary so widely depending on where you live. What's standard practice or required in, say, California might be very different from Texas or Florida. It leads to a real patchwork nationwide.
Let's pivot now and talk specifically about the Affordable Care Act, the ACA, because that really was the most significant overhaul of the U.S. healthcare system since Medicare and Medicaid were created way back in 1965.
Absolutely. It was landmark legislation. The ACA's core goals were pretty clear. 1, dramatically expand health insurance coverage to reduce the number of uninsured Americans. 2, implement reforms aimed at controlling the growth of healthcare costs. And 3, improve the overall quality of care delivered.
And it wasn't trying to scrap the whole system, right?
No, that's a key point. It was fundamentally an incremental reform. It aimed to build upon and regulate the existing public-private system, the employer plans, the individual market, Medicare, Medicaid, rather than replacing it entirely with something like a single-payer system.
And its biggest success, arguably, was on the coverage front. It really did expand insurance significantly.
Without a doubt, that was its most significant achievement. The ACA successfully cut the uninsured rate roughly in half. By 2016, estimates were that 20 to 24 million additional people had gained health coverage who wouldn't have had it otherwise.
Wow.
And that trend continued, with the uninsured rate falling to a record low of just 7.7% by 2023.
How did it achieve that? I remember hearing about a three-legged stool approach.
Yes, that's a common way to describe the core coverage expansion mechanisms. The first leg involved major insurance market reforms. This was huge. It prohibited insurance companies from denying coverage or charging people higher premiums just because they had a pre-existing health condition. It also banned annual and lifetime dollar limits on essential coverage. And it allowed young adults to stay on their parents' health insurance plans until age 26. These were really big consumer protections.
Okay, so protections first. What was the second leg?
The second leg combined the individual mandate and subsidies. The mandate was the requirement that most individuals maintain health insurance coverage or pay a penalty, though that penalty was later reduced to 0 by Congress, weakening the mandate's effect. But crucially, this was paired with the creation of the health insurance marketplaces we talked about, and, very importantly, substantial federal subsidies. Those premium tax credits to help people with low and moderate incomes afford the premiums for plans bought on those marketplaces.
Making insurance actually affordable, not just available.
Exactly. That was the goal. And the third leg was Medicaid expansion. The ACA allowed states to expand their Medicaid programs to cover nearly all adults with incomes up to 138% of the federal poverty level, a group that previously often fell into a coverage gap, making too much for traditional Medicaid but not enough to afford private insurance.
But didn't the Supreme Court change that?
It did. In 2012, the Supreme Court ruled that the federal government couldn't force states to expand Medicaid. It made the expansion optional for states. As a result, about a dozen states, mostly in the South and Midwest, chose not to expand their Medicaid programs, leaving millions of low-income adults in those states in that coverage gap, still uninsured because they don't qualify for traditional Medicaid, but also don't earn enough to get subsidies on the ACA bundle places. It's a persistent gap.
So beyond just getting more people insured, how did the ACA impact the way healthcare providers like doctors and hospitals actually operate day to day?
Well, the ACA did several things there, too. It mandated that most health plans cover a specific set of essential health benefits, things like maternity care, mental health services, prescription drugs, preventive care, ensuring a baseline level of comprehensive coverage. It also really spurred the growth of those value-based care models we mentioned earlier, like accountable care organizations, ACOs, where groups of providers coordinate care for patients and share in savings if they meet quality and cost targets, and bundled payments for episodes of care.
So what did that mean for providers? Was it good or bad?
Kind of a mix, really. On the one hand, having more patients insured was definitely a benefit. It meant hospitals and doctors had fewer costs from treating uninsured patients who couldn't pay their bills, less uncompensated care.
Okay, that makes sense.
But on the other hand, providers also face new challenges. Some plans sold on the ACA marketplaces had, and still have, relatively narrow provider networks, which could limit patient choice and sometimes excluded certain hospitals or specialists. And the rise of high-deductible plans, both on and off the marketplaces, created new headaches for providers in trying to collect payments directly from patients who might struggle to afford those large upfront costs.
So wrapping up on the ACA, it sounds like it was a massive step forward for getting people covered, but maybe didn't solve the underlying cost problem.
I think that's a very fair summary based on the sources. While the ACA was undeniably a landmark achievement in expanding health insurance coverage, it really wasn't a cost revolution. It addressed the problem of the uninsured far more effectively than it fundamentally tackled the underlying drivers of why U.S. healthcare is so expensive in the first place. It regulated the existing system, but left the basic price structure largely intact.
Which means that even with the ACA, the U.S. healthcare system still faces these really deep-seated, persistent challenges. Issues around cost, access, and quality. And it seems like these aren't separate problems. They're kind of interlocking, feeding into each other.
They absolutely are. It's like a vicious cycle sometimes. Let's break them down.
Okay, first the big one. Cost and affordability.
Yeah, the crisis of cost and affordability is pervasive. Data shows just under half of all U.S. adults, 44%, report that it's difficult for them to afford their healthcare costs. And that's not just the uninsured, though. 82% of them report difficulty. It's also a huge chunk of people with insurance. 42% of them say it's hard to afford care.
And what are the consequences of that? People skipping care.
Exactly. Around 36% of adults report having skipped or postponed needed medical care because of the cost. Yeah, and about 1 in 5 adults say they haven't filled a prescription because they couldn't afford it.
Which, of course, can make health problems worse down the line.
Absolutely. Delaying care often leads to worse health outcomes and can end up being much more expensive in the long run. This financial strain also shows up as widespread medical debt. In 2022, a staggering 4 in 10 adults, 41%, reported having debt due to medical or dental bills. Imagine having insurance, going for a necessary procedure, and still ending up thousands of dollars in debt. That's the reality for millions.
Okay, so cost is huge. What about access? Isn't that just about being uninsured?
Being uninsured is definitely a major barrier, but barriers to access go beyond that. As we discussed, millions of people are underinsured. They have insurance, but their deductibles or copays are so high, they still can't afford to use it when they need it.
Right, the deductible trap.
Exactly. Plus, there's a growing shortage of healthcare professionals, especially in primary care. Projections suggest the U.S. could face a shortfall of up to 124,000 physicians by 2034. This creates what are often called healthcare deserts, particularly in rural areas and underserved urban neighborhoods, where it's just physically difficult to find a doctor or clinic nearby.
Yeah, if you live hours away from the nearest specialist.
Right. And then there are non-financial barriers, too. Things like lack of reliable transportation to get to appointments, language barriers, difficulty navigating the complex system. Access is multifaceted.
And the third big challenge area, quality and disparities. The U.S. is known for medical innovation, so is quality really an issue?
Well, it's complex. We do lead the world in medical innovation and cutting-edge treatments. But the quality chasm and health disparities mean that this innovation doesn't consistently translate into better health outcomes for the entire population. There are vast and incredibly persistent health disparities across racial, ethnic, and socioeconomic lines in the U.S.
Can you give an example?
Sure. The data is stark. For instance, the infant mortality rate for Black babies is nearly 2.5 times higher than it is for white babies. And Black Americans, on average, have a life expectancy that is years shorter than white Americans.
That's shocking.
It is. And these inequities aren't just about income. They're rooted in complex factors, including systemic biases within the healthcare system itself, as well as broader social determinants of health, things like housing, education, environmental factors. It reveals a system that simply doesn't serve all Americans equally well.
After looking at all these internal challenges, cost, access, quality, disparities, it really begs the question, how does the U.S. truly stack up against other wealthy, developed nations? It brings us right back to that American healthcare paradox we started with.
Yeah, and when you look at the international comparisons, the U.S. is consistently a major outlier, usually not in a good way, unfortunately. First, spending. As we said, we spent over $12,700 per person on healthcare in 2022. That's nearly double the average of around $6,800 for comparable high-income OECD countries.
Double the spending. But what about the results?
That's where the paradox hits hard. On key health outcomes, the U.S. is consistently worse despite the higher spending. Our life expectancy is nearly 5 years shorter than the average of comparable countries. Our infant mortality rate is significantly higher. Our maternal mortality rate is more than double the average, truly alarming. And we have more deaths that are considered preventable or treatable with good health care.
So more spending, worse outcomes on average. Are there any areas where the U.S. system performs well internationally?
Yes, it's important to acknowledge the strengths too. The U.S. is, without question, the global leader in biomedical research and technological innovation. We develop many new drugs and treatments, and the system often performs well on measures of patient-centered care, things like involving patients in decisions about their treatment, and relatively low wait times to see specialists compared to some other countries.
So innovation and maybe faster access to specialists, but what about the weaknesses?
The weaknesses are significant. We already talked about the poor outcomes relative to spending. The U.S. was also ranked dead last 32nd out of 32 high-income countries on measures of fiscal sustainability because our costs are so high and growing. We also rank poorly on measures of disease prevention and overall healthcare infrastructure. For example, we have the lowest number of primary care physicians per capita among comparable nations.
Fewer primary care doctors. That probably contributes to the access issues we discussed.
Almost certainly. And this overall performance or underperformance connects directly to how Americans feel about their system.
Right. You mentioned public opinion.
Yeah. Studies consistently show that Americans report the highest levels of dissatisfaction with our healthcare system compared to citizens in other wealthy countries. One prominent survey found that 34% of Americans, over a third, believed their healthcare system needed to be rebuilt completely. That was a far higher share than in any other country surveyed.
So a lot of frustration out there. Given all this context, the high costs, the mixed outcomes, the public dissatisfaction, what does this all mean for the future? Healthcare reform is always being debated, isn't it? It seems like a continuous and often really polarized political battle.
It absolutely is. And the partisan divide, particularly over the Affordable Care Act, remains pretty central to the ongoing debate. Generally speaking, the Democratic approach tends to focus on strengthening and building upon the current system, the ACA framework. Things like trying to make those enhanced premium subsidies for marketplace plans permanent, expanding Medicare's new power to negotiate prescription drug prices for more drugs, or maybe even creating a government-run insurance plan, a public option, to compete with private insurers.
Okay, so build on the ACA. What's the general Republican approach?
The Republican approach has largely centered on efforts to repeal and replace the ACA. Past proposals often focused on ideas like converting the federal funding for the ACA subsidies and Medicaid expansion into block grants given directly to states, giving states much more control but likely less funding overall. Other ideas have included promoting health savings accounts, allowing sales of less comprehensive insurance plans, and potentially rolling back some federal regulations, possibly including some protections for people with pre-existing conditions, though that's politically very sensitive. So fundamentally, very different visions for where to go.
It sounds like really different philosophies. But are there any specific policy areas where maybe, just maybe, there could be some bipartisan agreement? Smaller, incremental reforms that both sides might see value in?
Yes. Despite the big divides, there are a few areas where you sometimes see broader interest or potential for common ground. One is prior authorization reform.
Ah, yes, the bane of doctors and patients.
Exactly. There's widespread frustration with the administrative burden and the care delays caused by prior auth requirements. So efforts to streamline or standardize that process often get bipartisan attention.
Okay, what else?
Telehealth expansion is another one. Telehealth use exploded during the COVID-19 pandemic when regulations were temporarily relaxed. It proved popular and convenient for many patients and providers. So there's broad support for making many of those temporary flexibilities permanent.
Makes sense. It seems like a win-win in many cases.
And a third area is price transparency. There's ongoing interest from both parties in efforts to require hospitals and sometimes insurers to be more transparent about their actual prices, with the idea that this could empower consumers and maybe foster more competition to lower costs. Though the effectiveness of transparency alone is still debated.
So some potential for smaller tweaks. But what about the really big picture? You still hear talk about Medicare for all.
Right. Beyond these incremental changes, the long-term Medicare for all debate looms in the background. This represents a much more fundamental, disruptive proposal. Essentially, it advocates for replacing our current complex multi-payer system with all the private insurers, employer plans, etc., with a single government finance system, like an expanded Medicare program, that would cover all Americans.
It's a single-payer system.
Exactly. While it's not currently the main focus of political leadership in either party, the idea itself is important because it frames the long-term ideological debate. It offers a completely different alternative model to the current hybrid public-private system. It forces a conversation about fundamentally different ways to structure and finance healthcare.
Wow. What a deep dive this has been. We've really journeyed through this incredibly complex U.S. healthcare system, a system that, as we've seen, spends just vast amounts of money,
Unmatched amounts globally.
yet still struggles with these persistent interlocking challenges of access, affordability, and achieving the health outcomes we'd expect for that level of investment. And these aren't just abstract issues or statistics. They represent very real, often difficult human experiences for millions of people, as you've highlighted so clearly.
Absolutely. And I think ultimately the central challenge, the core puzzle for U.S. healthcare, is how to finally reconcile its enormous expenditures with its often underwhelming performance. How do we address these interlocking crises of cost, access, and quality that continue to leave so many Americans financially vulnerable when they get sick and medically vulnerable even before that? That remains the fundamental question.
It really does. So, as you, our listener, go about your day, maybe take a moment to consider how much of what you've heard today, the costs, the coverage pathways, the quality concerns, impacts your own choices about your health, your finances. And maybe think about what that might mean for your family, for your community. It's a system we all interact with. And just understanding its complexities, its paradoxes, is maybe the first crucial step toward thinking about its future.